Good morning and welcome to the 21st meeting of the Health and Sport Committee in 2020. We have received apologies today from Alex Colehan. The first item on our agenda is an evidence session on the budget 2021 to 22. The committee's approach to scrutiny of the budget reflects that recommended by the Budget Process Review Group and entails addressing budget implications throughout the year, bringing this information together to inform our pre-budget report for consideration by the Cabinet Secretary. This year we're also, because of the impact of COVID-19 on health and social care, we're also undertaking our pre-budget scrutiny with that in mind in relation to the current year's budget of 2020-2021. And we will be taking evidence from a number of bodies on this during the course of this month, and we will hear at the end of the process from the Cabinet Secretary for Health. At the third of this series of meetings, we are hearing today from NHS Ayrshire and Arran, and I welcome to the committee Hazel Borland, Interim Deputy Chief Executive and Nurse Director at NHS Ayrshire and Arran, and Derek Lindsay, Director of Finance, also. We will take questions in a pre-agreed order, as is the way of proceedings in the context of our online meetings. And I want to start with a look at the impact of COVID-19 on the delivery of health services in the Ayrshire and Arran area. The board has identified a number of impacts, direct impacts and indirect impacts of COVID-19 on the delivery of services in the area. And I'd like to start by asking what assessment has been made of the potential indirect health impact of COVID-19 from the drop in performance in areas such as inpatients, outpatients, imaging and endoscopy. Hazel Borland.
Thank you, Convener. So our assessment has shaped our remobilisation plan. And so, as you would imagine, our focus has been on enabling that process to be clinically led and clinically prioritised, making sure that we are making that assessment in line of robust infection prevention and control, as well as making sure that we are enabling those services and the assessment that we make to focus on safety of our patients, safety of our staff and safety of our communities. And at the moment, our impact has been right across our whole health and care system, and we in particular have seen focus in terms of our the services that we've been able to provide, and we're focusing on how we restart those services. We've had an impact on our workforce, and so we are making an assessment of the workforce needs that we will have going forward. And we've also absolutely been focused on our test and protect system to make sure that we can meet the demands of that. And wrapped around that, then we're absolutely making a financial assessment to make sure that whatever needs assessment and clinical prioritisation we make to enable our services to restart, that we're very clear about what the financial impact of that will be, both in terms of what it's been so far for the first 5 months of this year, what it will be going forward until the end of March 2021, and what we think that might look like in terms of 2021-2022. I'm happy to take any detailed questions in terms of specific health and care services, Convener, and my colleague Derek Lindsay, as Director of Finance, may have more detail in terms of the financial assessment that the committee may want to hear at this point.
Thanks very much. Before we go on to the finance, I wonder if I can ask just in general terms whether you feel you've been able, in the context of the lockdown, all the difficulties that brings with it, have you been able, in your view, to strike the right balance between the direct health impacts of the COVID crisis, the indirect impact, delays in services and so on?
We've tried very hard to make sure that we have focused on understanding the impact of being unable to deliver a range of our services and manage through a variety of community-focused means in terms of enabling our communities and our population to stay as well as we possibly can. So in terms of focusing on our shielded communities, there were 16,000 across our communities that were shielded, so we've really tried hard to focus and make sure that the needs of that specific vulnerable community across Ayrshire and Arran, and make sure that they were supported in the best way that we could. And our prime focus has been on maintaining safety and maintaining contact across a whole range of vulnerable communities to make sure that we are sighted on their needs and that we can enable the impact on these vulnerable communities to be as minimal as possible, but recognising that there will be an inevitable impact, and what we're trying to do is make sure that we can plan for that as much as we possibly can.
Thanks very much. In addressing the question we asked you of what steps you're taking to work with services that have been impacted by COVID, one of the things you said that you would do was to validate waiting lists. Can you explain what the validation of waiting lists means? Hazel Morland.
Thank you. That validation has enabled our clinicians for each of those specialties to drive that process and to review the waiting lists, to look at the patients and members of the community who are on those waiting lists and prioritise and look absolutely at their clinical need. So as we have restarted services, we've restarted approximately 87 services to the end of last week. That's enabled our clinical teams to make sure that the patients with the highest clinical need are getting seen first, and that may not necessarily be where you are on the waiting list. And so what we've absolutely enabled those clinical teams to do is to clinically prioritise and make sure that the patients with the greatest clinical need are getting seen in a timely manner, and that means that they're able to really make sure that the patients who need them most are getting seen first.
And so that's quite a complex and I imagine difficult process. Essentially that means that people who are on the waiting list are still on the waiting list, but they may be further back and further away from treatment than they would have anticipated under ordinary circumstances. Is that a process that involves a lot of clinical effort to identify those priorities in the way you've described?
Absolutely. Absolutely, convener. It does, and it's required an awful lot of effort and time and resource from our clinical teams, but it's something that they have absolutely wanted to do to make sure that they have clinical control and that they have clinically led that process, because that is the right thing to do. For example, our surgical restart group is being led by one of our consultant surgeons, and that is also a clinically led group to make sure that the services that have restarted at this point in time have absolutely had that clinical focus, that clinical prioritisation in mind, and have thought through all those different needs and the clinical pathway from end to end.
The difficulty, I suppose, if you're not seeing patients because of the restrictions they're under and the restrictions on your services, is how you have the up-to-date clinical knowledge to make those prioritisation choices in a different way from perhaps they would have been made 6 months.
And so that has involved conversations with other colleagues. So if the consultant for that specialty has felt the need to maybe contact the patient's GP again to look at their most up-to-date blood results, to also understand what some of those investigations might mean, to see if further diagnostics are required, recognising the limitations on those at this point in time as well, and particularly over the last 5 months. But also clinicians have been able to and have absolutely been undertaking a range of interventions with patients. So we've been holding telephone consultations, we've been using NHS Near Me, and we've also been seeing face-to-face consultations when that clinical need has absolutely demanded it. So yes, a significant number of those face-to-face consultations stopped, and that was right and proper, but there have been a small number of patients who absolutely, from a clinical perspective, the consultant and the wider clinical team have felt we really need to see this patient so that we can make a proper assessment, and those have absolutely taken place.
Thank you very much. And finally from me, the overall impact you've described, creating extra capacity or accessing capacity outside the board's area, for example, at Golden Jubilee. Have you made an estimate of what it will cost the board in order to get your performance measures back on track? Hazelbourne.
In terms of the financial estimate to get back on track, I would need to pass that question to Derek Lindsay as Director of Finance, but in terms of that level of detail, but we are absolutely in direct communication and collaboration with the Golden Jubilee and with the NHS Louisa Jordan so that we can plan for that, and more than happy to share a level of detail about what we anticipate and we'll be using those facilities for at some point during the meeting.
Thanks very much. I expect we'll return to Derek Lindsay once he's rejoined us, but in the meantime, I'll pass over to my colleague, David Stewart. David Stewart.
Thank you, Convener, and good morning to our witnesses. Could I continue on the theme of waiting lists and ask about your estimation such as this will return to pre-COVID-19 levels of performance?
I'm sorry, I lost part of the question there, but I think that was when do we think we will get back up to our pre-COVID level of performance? Yes. I can advise that as at the end of July, from an inpatient and a day case perspective, we were operating at 46% of our performance, and due to the need to maintain safety, PPE, social and physical distancing, and the impact that that has across a whole range of our environments and facilities in terms of staggering appointments, in terms of theatre capacity, and patients, the number of patients on lists. So, then at this point in time...
Now here, Hazel.
Oh. Do carry on, Hazel. I think Derek Lindsay has just rejoined us. Please carry on.
Sorry, thank you. At this point in time, we're really uncertain as to whether we are going to be able to, when exactly we're going to be able to get back to pre-COVID levels. But at this point in time, we are at less than 50%, in common with a number of other boards across Scotland. And with the current restrictions, then we don't anticipate that changing significantly beyond 60% by the end of the calendar year, and potentially to the end of March 2021, because of the need to maintain those safety measures to prevent the transmission of infection.
David Stewart.
Thank you, Convener. Thank you. That was a very helpful answer. And finally, what impact would a second wave over the winter have on performance in terms of timescales, health outcomes and finance?
Hazel Borland.
So if we experienced a significant second wave, then I anticipate that we would go into very similar cessation of activity from a safety perspective. So exactly the same mechanisms that we've had in place at the beginning of the pandemic. We would need to increase our intensive care capacity. We would need to cease elective activity. We would need to move back from a primary care perspective and community care perspective into the digital way of seeing our patients. And so the only impact that that would have on waiting times would be to increase them if we had a significant second wave. And absolutely the worry would be on the impact of health outcomes across our population and in terms of those patients who had needs that were waiting to be met, and we would need to assess those at the time that that happened. But I think there is no doubt that if we have a second wave, then we would need to carefully consider cessation of elective activity again in order to make sure that we could meet the anticipated COVID-related need.
Thank you very much. I think Derek Lindsay is now online again, so can I ask Derek Lindsay, in relation to the extra capacity that's been created in Ayrshire and Arran following the lockdown and attempting to restart services, has there an estimate been made of the potential cost of creating extra capacity in order to get performance measures back on track? Derek Lindsay.
Thank you, convener. So we are required to have double our ITU capacity immediately available within a week, and the capacity to increase to 3 times our normal capacity within 2 weeks. So that incurs additional cost. We have created COVID beds for patients who come into hospital with COVID, and carrying forward our testing is a significant additional cost. So we submitted a remobilisation plan at the end of July to Scottish Government, which set out all the additional costs that were identified. We require public health capacity to deal with outbreaks, and indeed our colleagues from local government and within the health and social care partnerships have identified costs in supporting the provision of protective equipment for their staff and in sustainability payments to councils for care home providers. So in total, the requirement that was identified is about £67 million for the remainder of this year, from 1st of April through to the end of this year, for all of those costs.
That includes IJB additional costs as well as...
Correct, yes, that includes IJB costs.
Okay, thank you very much. And I'll hand over to my colleague, Brian Whittle.
Thank you, Convener. Good morning, Hazel and Derek. Can I move on to the topic of delayed discharge, if I could? And I know, like many NHS boards during this pandemic, the delayed discharge was severely, the numbers fell severely during that time. And in Ayrshire and Arran, for example, in April, it went from 129 in March to 52 in April. The government made some funding available to allow that to happen. Can I ask you how that additional fund was used to reduce that delayed discharge number?
Hazel Borland.
Thank you. We used that funding across a range of opportunities. Some of that enabled us to fund additional beds in some of our community settings. Some of that enabled us to fund additional care at home, and some of that enabled us to fund additional health and care staff so that we could care for more people in their own homes. So we use that funding across a range of settings. In some cases, we specifically commissioned care beds in care homes. In some cases, it enabled us to plan to open beds if required in our community hospital settings. So we really try to think about that across a portfolio of opportunities so that we could maximise that as much as possible as the need arose.
Brian Whittle.
Thank you. Can I ask us one of the things that I think is quite interesting here is you've kind of been forced during this pandemic to make some significant changes in the way you approach delayed discharge, but have you had an opportunity to maybe do a cost-benefit analysis, as in the cost of looking after those patients in their own home or in care homes versus maintaining them in a hospital setting? So that additional funding, has that impacted your potential, finances going forward?
Hazel Borland.
We have not yet had the opportunity to do that cost-benefit analysis. I've got no doubt that it's something that going forward, in terms of building on our ambition, in terms of really making sure that we can deliver as much care as possible close to home and in our communities, it will be something that we'll look at. But at this point in time, the kind of cost-benefit analysis you described, we've not yet had the opportunity to look at that, but I'm sure that we will, given time, to make sure that we understand exactly what the impact of that has been.
Derek Lindsay.
We have been working with our integration joint boards to look at the best balance of care, and as well as being clinically better for patients not to remain in hospital longer than they have to because their independence deteriorates, etc. The cost that we were looking at there compared to care in a care home is about a quarter of the cost of keeping somebody in hospital, and if they can be supported in their own home, that's even less. So there is a financial benefit in minimising the number of people in hospital, and obviously that's one of the objectives of our integration joint boards, is also to commission and support the right balance of care. So there are costs and benefits that are seen in moving and shifting the balance of care, which of course has been Scottish Government policy for some time.
Brian Whittle.
Just a brief supplementary to that one. To maintain that level of reduced discharge, do you think that there's an increased level of funding will have to be maintained?
Derek Lindsay.
So there has been that. It's about maintaining where we currently are at, which is an improved position, and working with our integration joint boards. They will require to have sufficient funding to be able to maintain the current capacity, but also with a demographic of increasing elderly population, there is a need for that to continue to increase. Clearly, the Scottish Government need to consider what is the right balance in terms of health and health board funding and IJB funding, but we are working very well with our local integration joint boards to see that change happen and establishing the right balance of care.
And very briefly, you indicated additional costs earlier. Can you indicate the saving, the level of saving that comes from a delayed discharge over this period? Derek Lindsay.
So we most of our costs are fixed in terms of staffing costs, etc. So the reduction in delayed discharges allowed us to meet the increased demand of numbers of patients with COVID coming into our hospital, and we are now currently operating at up to 90% capacity. So there isn't really a cost saving that we have seen. However, it's utilising the available resources that we have to the best effect, and that balance can be more treatment in the community where patients can be supported in their own home or in a more homely setting.
Hazel Borland.
On what Derek has described, then the element of what we are not able to put a cost on at this point in time is the way that our communities contributed to keeping their own residents and neighbours safe in the community. So the way that we were able to do this was across our whole health and care system with all our partners, and our communities absolutely pulled together to enable their own to stay at home and be safe at home, and so one of the real benefits in terms of what we've seen has been how our communities have pulled together and really worked alongside some of those statutory services to enable some of those residents to stay in their own home when, 6 months, 12 months ago, that would not have been an option, even with all the health and care services that we've got. So a key learning for us as we move forward and continue to build on our 10-year plan in terms of caring for Ayrshire will be learning the lessons about how have our communities worked together across our whole health and care system and with us and alongside us, so that we can really take that forward for the future and maximise that learning.
Very much. Brian Whittle.
Can I move on to another hot topic at the moment, is testing capacity, and I think there's quite a lot of anecdotal evidence as it is that the patients are being asked to travel quite a distance to get a test, which would suggest that perhaps our testing capacity is under a bit of pressure. So can I first ask if there's been an upsurge, or have you noticed an upsurge in the number of tests carried out since schools reopened?
Hazel Borland.
Absolutely. We have capacity to undertake approximately 420 tests a day in our NHS lab, and we focus that according to clinical need. We focus that on our asymptomatic key workers as well as symptomatic key workers. our symptomatic patients, our pre-operative work, and we've also then made a commitment to our partners in terms of education and managing outbreaks. So the increase in requests has been to get tests undertaken and has been through the single point of contacts that we've established with our local authority colleagues to enable those tests to be coordinated. The significant testing increase has been through the portals to get those testing facilities rather than the NHS setting. The NHS setting and our laboratories have seen an increase in demand due to our test and protect and our contact tracing recently. That's where that increase in demand has come, but the portal has seen an increase in demand from our education colleagues as schools have gone back in terms of families and school children, and indeed teachers as well, and others from the school-based setting. So yes, we absolutely have seen an increase.
Brian Whitlam.
Well, finally then, if I could, convener, would you think there's adequate testing capacity within Ayrshire Island to cope with this increase in demand?
Hazel Borland.
At this point in time, we're undertaking an assessment of that. So we are recognising what we currently use our NHS lab for, and we are undertaking a risk-based scoping assessment to understand if we were to reduce the asymptomatic testing and surveillance that we undertake in our NHS lab, what capacity would that give us in order to meet the clinical need of our symptomatic members of the public and symptomatic staff, as well as the contact tracing need, and we're undertaking that assessment as we speak. At the moment, we have sufficient capacity working together with our portal colleagues and our lighthouse facilities. At this point in time, we have sufficient capacity across that collaborative working. The challenge will come if the lighthouse facility capacity cannot meet the demand that we've got in terms of our care home colleagues and our education colleagues. That will then present us with an additional challenge that we need to meet, and that will be on a national basis.
Thank you. And briefly, Derek Lindsay.
Hazel was saying there are 4 steps involved in the testing process. There is taking the swab, which, for example, the lighthouse units in airport car parks do. There's analysing in the labs. There's then reporting the results, and there's the follow-on contact tracing. So it's very important that the capacity of all 4 of those are aligned and one of them doesn't become a bottleneck in the process. So we are very glad to have access to the lighthouse unit for some people to be able to go and book a test and get that there. And we also have our own in-house testing facility and drive-through facility for that. The analysis in the labs is both local, regional, and at the lighthouse labs. And then we have our results reporting hub. So we are increasing the staffing in all of those over the month or 2 coming, but we have already started that process, both to recruit people to do the swabbing. We've increased staffing within the labs, and our results reporting, where we have been using people in the past who have been redeployed. We're bringing in additional staff, and obviously for contact tracing also.
Thank you very much. Now move to my colleague Emma Harper.
Thank you, convener. Good morning, Hazel. Good morning, Derek. I've got a couple of questions about the innovation practices that we've seen since the pandemic and ensuing lockdown. And we know that there's been a number of innovative practices that have evolved, and some of them we were looking at, like pushing for some time, but then there's been rapid adoption of such things like Near Me, which is the video consultation, and there's also been a virtual review of appointments. So I'm interested in hearing about any other innovations that have been adopted during lockdown that will be either retained or extended after this COVID-19 pandemic.
Hazel Borland.
Thanks very much. So you're absolutely right. We have our staff being incredibly innovative to make sure that they can continue to provide services to patients and work together as colleagues across our health and care system. A range of those have been digital in nature, so we moved to something like 30 or 40 people who had the ability to network and work from home to a number of 1,000. We were able to increase the NHS Near Me consultations as well as using telephone. Those two things will absolutely stay as ways of working as we go forward, because the ability for our staff to work and stay connected to their clinical networks from wherever they may happen to be is absolutely of benefit to the patient and enables them to work more strongly as a team across that health and care system. So that absolutely will stay. Patients have told us that they really enjoyed and liked being able to have a telephone consultation or have an NHS Near Me consultation. It meant that they didn't have the stress of getting to a facility, of driving there, of getting parked, of having to think about coming in to a hospital facility. A number of our patients and families have told us that they were quite anxious about that, and so they wanted to, that the idea of being able to do that from the safety of their own living room was really welcomed. So I have no doubt that we will be keeping those innovations. Increasing the range of public Wi-Fi across our systems has also really helped patients and families stay connected at a time when we absolutely had to reduce the footfall across our hospital facilities, across our health and care system, and so that was also welcomed, and I've got no doubt that we will also be keeping that to enable our patients to stay in touch with their families and loved ones. Some of the other innovations have been about how clinical teams have worked together. So, for example, we are very clear that our clinical hub and our assessment centre and how we have absolutely connected that and co-located that with our out of hours and our urgent care system has absolutely been an innovation for us and has been a very strong way of working that we're absolutely anticipating that we will continue going forward after the pandemic. And we're also thoughtful that a range of clinical teams have innovated in the way that they deliver services to patients, being able to deliver that online, whether that's breastfeeding classes, whether that's musculoskeletal classes and our cardiac rehab classes. So we've got a range of clinical interventions as well that I have no doubt we will absolutely be keeping because we've had really good feedback from patients and families.
Emma Harper.
Thank you. I just thought about Near Me. It's a multidisciplinary tool that can be used, but does Near Me have any particular specialties that it works or can work really well for, such as mental health, for instance? Is that something that Near Me can really be a benefit for our members of the public?
Hazel Morland.
There's a range of specialties that NHS Near Me has proved to be successful for. Some of those have been across our mental health specialties, so enable our mental health community teams and specialties to stay in touch with patients, but also some of our surgical specialties, as well as some of our medical specialties, and our clinical nurse specialists and our AHP colleagues have found NHS Near Me valuable. The other thing that we were able to use it for was to enable virtual visiting. So we used NHS Near Me to enable some of that virtual visiting rather than things like FaceTime or Skype. We found that Near Me actually worked really well for that.
Emma.
Thank you, Convener. Just a final question around whether there's been an assessment of the value of the Near Me interventions or the other innovations. We know that people have been happier not driving, for instance, a 150-mile round trip if it was in Dumfries and Galloway, as Hazel knows, as my former chief nursing officer. But we know that there's been a lot of time saved or reduction in mileage, so that's been important. So has any value or been assessed for the implementation of the innovative Near Me solutions?
Take Hazel Borland and then Derek Lindsay. Hazel Borland.
There's absolutely no doubt, Emma, that using some of these virtual ways and digital ways of connecting with our patients has released clinical time. So there's an element of that. But what staff have also found and patients have valued is that actually some of those virtual consultations, for example, have been able to have more time dedicated to them. And so it's meant that the patient and their clinical team have been able to interact in a different way. So there's an element of that, and we're in the process of understanding both from our clinical teams and patients and families, what have they valued about that, what difference has it made, what do they want to keep, as well as understanding what has it enabled our clinical teams to do better and differently, and is there something that they can now do in addition to that because they're working in that different way. So we're working through some of those impacts with our clinical teams at this point in time. But there's no doubt the reduction of travel, the reduction of mileage, the reduction of travel expenses, all these things will absolutely impact and enable us to really measure the difference that that's making for our clinical teams and our patients.
Derek Lindsay. We're not hearing Derek's sound. We'll perhaps come back to Derek in a moment when we have the opportunity to do that. For the moment, I'll move on to my colleague George Adam. George.
Thank you, Convener. I'd like to ask a question, following on from Emma Harper's question actually, on innovation, but particularly with regards to integration between health and social care. And my main question would be, what are the lessons that have been learned during the pandemic with regards to integration? Did integration rise to the challenge of the pandemic? And what were the key challenges?
Hazel Borland.
We've got really strong foundations that we were able to build on during the pandemic. So we work incredibly closely with our health and social care partnership colleagues and our integrated joint boards, and we were able to build on those strong relationships. Our lessons were, first of all, that those relationships enabled us to work very closely together. It enabled our teams to really remove the barriers. Myself and the Chief Exec and our Medical Director have been going round over the last 3 or 4 months talking to teams to understand what made the difference for them, and it absolutely was about removing barriers. It was about enabling teams to work much more closely together, enabling them to work across that health and social care divide in a way that they had been trying to, or tinkering around the edges, or had a desire to. And what the pandemic enabled them to do was remove any of those barriers and absolutely just rise to the challenge. And they have done that in a phenomenal way. And that absolutely is something that, as we go round again talking to teams, we're keen to get their ideas on how we make sure that those barriers don't go back up again, and that we enable our teams and our colleagues to continue working in that way. So I would say that yes, in Esher and Arran, how we work together as a whole integrated health and care system absolutely made the difference.
Thank you, Convener. Yes, Hazel, it's quite interesting because as a former councillor and elected member here since 2011, I've heard about barriers and breaking down barriers of various organisations, but it is key to the integration of health and social care. And my question to you would be, why is it taking a worldwide pandemic to get to the stage where we're breaking down these barriers?
Hazel Borland.
I think that's a very fair question, and what I would say again is that across Esher and Arran we've got a strong history of already working very well together across our health and care system, and we are absolutely consider ourselves to be a single health and care system, and some of the barriers that staff were describing were some of those small barriers that they see at their level in terms of being different teams that are employed by different bodies, for example. So some of those slightly different working conditions, some of those slightly different ways of working, and so what the pandemic has enabled was things that ways of working, collaborations that teams were already taking forward, some of the nuances and the deliberations dare I say, some of the bureaucracy, that absolutely the due process in terms of working through those, what it enabled us to do was get through those quicker, and it enabled us to really understand what they were in a different way with a different lens. So it absolutely has been about speeding up a process and a journey that we were already on, rather than it being the reason that we were doing it in the first place.
Georgia.
Thank you, Convener. Finally, I just want to, can you explain to me, Hazel, just give me some experience of the pandemic, highlight some areas where you've actually improved structures in place for decision making and allocation resources. Can you tell me, is there anything in particular you can actually tell me that has changed and will continue to work that way because of what's happened?
Hazel Borland.
So during the pandemic, from an NHS board perspective, we very swiftly established our emergency management team. And one of the things that we've absolutely recognised has been of benefit, that has enabled us to make decisions very swiftly and in a very informed way, has been establishing silver and bronze specific groups with the right people in those to undertake bespoke pieces of work, understand the change that's required, and really then pull together and enable the delivery of those changes in a very different way. And that structure, we are absolutely now looking at how we can keep that structure in an improvement way, and it's worked across our health and care system. So it's meant that staff from across all our organisations have been in the room together and have been making those decisions, feeding them up in a very swift way without having to go through a process of potentially a number of committees. We've streamlined that process, and my anticipation is that we're looking at ways to enable us to keep that streamlined process, to enable us to make those decisions that we need to in a very swift way. And we've done that across our health and care system, regular meetings with the NHS Chief Exec and our Council Chief Execs and our other partner colleagues in terms of our local resilience partnership. And so we're absolutely anticipating keeping that for the foreseeable future at this point in time, to make sure that we've got that collegiate oversight of issues that need to be taken forward and decisions that need to be made.
Thank you very much. I take it that means delegating and empowering staff is really part of that, the answer you're describing there. Can I ask what the Imperial Strategic Group in its report in January described the kind of criteria that IJBs should seek to achieve and health and care systems should seek to achieve, and categorise them as red, amber and green. I wonder if you could tell us where Ayrshire and Arran currently stands in relation to those criteria. Hazel Borland.
I would need to get a level of detail from colleagues specifically in terms of those red, amber and green criteria, but in terms of our strategic partnership, we met just yesterday, and I'm aware that the criteria that we were looking at, they were all green at that point in time. So on an individual IJB basis, then my anticipation is that they would also agree that that's where we are at this point in time.
Thanks very much. It would certainly be helpful to have that further detail as you describe. If you could let the committee have that, that would be appreciated. And finally, on that area, can you just indicate in terms of funding allocation whether IJBs in Ayrshire and Arran received any allocations in addition to those made under social care by the Scottish Government? Hazel Borland.
Thanks very much, Convener. I will pass that question to my colleague Derek Lindsay to answer, if I may. He's got a level of knowledge about that I think would be beneficial.
You may indeed, but I think we'll have to come back to Derek a little later.
Is he away then?
But I shall have that in front of me. Can I therefore move on to my colleague Donald Cameron?
Thank you, Convener. My questions are about financial stability. I don't know if Derek is available to answer these questions, because they're essentially funding questions. I'm happy to ask them, but I think they're probably not suitable for Hazel.
Yeah, thanks very much, Donald. I think we're still having some technical challenges with Derek Lindsay's connection. So perhaps if you can ask your questions, or at least begin your questions, and Hazel can address the general points. I'm sure she'll have a grasp of those, and then if we need more detail, then we'll come back to Derek later.
Thank you, convener. So my questions are basically, we know that NHS Ayrshire and Arran received £14.7 million from the Scottish Government in the last budget year, 2019 to 20. My question is, does the Health Board anticipate requiring further additional Scottish Government financial support in 2020 to 21? And if so, how much?
Hazel Borland.
Thank you. So I guess at this point in time, primarily due to our COVID situation, then yes, I think the answer is that we would anticipate requiring additional funding this financial year. Derek's already described the additional funding that we have received in his anticipation of to the end of year, that being 67 million. We had a financial recovery plan that we have continued to closely liaise with Scottish Government colleagues on in terms of making sure that we are as on trajectory as we can be to achieve that financial recovery plan. We will not be in financial balance at the end of the year. I can definitely advise that. And we are working closely with Scottish Government colleagues in terms of understanding our Q1 analysis and making sure that with COVID we've still got our eye on the financial requirements that we were aiming to achieve on that, and also aiming to describe and liaise with Scottish Government colleagues in terms of being on trajectory to deliver that or not in the context of COVID. So we continue to work very hard with Scottish Government colleagues along with other boards in Scotland. We've had a number of additional allocations to enable us to continue to deliver services, and those have been incredibly welcome. And that's probably as much detail as I could provide at this point, convener.
Thank you. Donald Cameron.
Looking at a longer time scale, does the board expect to achieve the aim of breaking even over a 3-year time frame, in line with the change to approach that was announced by the Scottish Government in 2018 that allowed these plans to be made over 3 years? Do you expect to achieve that?
Hazel Borland.
That is our absolute ambition. And we are working incredibly hard to make sure that we are sighted on that we've got realistic and deliverable ambitions and trajectories for our financial targets to deliver that do not impact on our service delivery. That means that we are having conversations across our whole health and care system about how we do that. It means that we are making sure that we're making the best use of innovations, and really making sure that we are focusing that financial planning over the 3 years and connecting it strongly to our 10-year vision and our Caring for Ayrshire plan, because those two things go very closely together in terms of being able to deliver health and care services in the most efficient, effective and safe, person-centred way, as well as making sure that over that 3-year period that then we are on track to deliver the financial commitment that we absolutely have stated that we will. So that is our absolute ambition.
Derek Lindsay.
I'm sorry that you couldn't hear me previously. Can you hear me okay now?
Yes, we can.
So yes, our 3-year financial plan, which was submitted to the Scottish Government at the end of March, does indicate that we will get to a break-even position within that 3-year period. We have been on a trajectory of reducing our deficit, and that is expected to continue. The impact of COVID and learning the lessons from the redesign that has happened quickly. Hazel has mentioned detail around things like near me and the outpatients and the way in which we deliver those services, and indeed in terms of urgent care, the aspects around community hubs and the redesign around the way in which we handle that. We hope will also give us benefits around having a sustainable system for the future.
Donald Cameron.
I was going to ask, my final question was about the effect of the pandemic on the financial trajectory, and I wonder if you could give any more details about that. In particular, I'm interested in the delay to operations and other perhaps standard care that the pandemic has caused. I mean, last week we saw the national picture of waiting times being, a lot of operations being delayed, etc. Will that have a financial impact?
Derek Lindsay.
So our capacity in terms of staffing, our diagnostic capacity, our theatre capacity is reduced as a result of COVID and for the period of COVID. So whilst during the initial 3 months or so there were many staff redeployed from those areas to deal with frontline services, and we need to see how things progress during the year. We are in a remobilisation phase, and those things like surgical services and outpatients are restarting. However, we do have a big backlog, and the capacity that we have to be able to challenge or to reduce that backlog is extremely challenging. So within our remobilisation plan, we have asked for additional funding and indeed received some additional funding already from Scottish Government. An example of that would be for a mobile MRI scanner, which is located at Ayr Hospital, and that increases our capacity. And we will also utilise capacity at Louisa Jordan and Golden Jubilee National Hospitals. And so we have a plan. However, we won't be able to address the whole of the backlog because the capacity that we have in terms of meeting our current referrals, etc., we'll be trying to balance that in the first instance. So I think we're talking about the long term in terms of recovery of the performance targets that you mentioned, Mr. Cameron.
And can I ask, Mr. Lindsay, have you received assurance from NHS Scotland about the additional one-off costs, if you like, of the COVID epidemic being covered and met?
Yes, we have received. Yes, we have received assurance from Scottish Government that the additional cost of COVID-19 will be met. There are a number of things which are centrally funded. So, for example, testing kits or personal protective equipment for NHS workers is provided free of charge, and that cost is met centrally. But for the additional cost for our extra capacity around ITU, COVID beds, and any other costs related to that, those will be covered by Scottish Government. So that's built into our financial reporting to our board on a monthly basis.
So in terms of additional funding that you may require for the current year, Hazel Borland indicated that yes, you would be looking for further additional financial support this year. What would that amount to, given what you said about items that are going to be covered in any case? Derek Lindsay.
So the remobilisation plan had a financial part to it, which indicated £67 million is required, but about half of that relates to community-based costs. So things like sustainability payments to care homes, or the costs of personal protective equipment for our social care workers in care at home context, etc., is included within that, as is the cost of unachieved efficiency savings, both for integration joint boards and ourselves, because we haven't been able to take forward some of our planned efficiencies this year. So that total of 67 million incorporates all of those things.
Thanks very much. Before I call my next colleague, can I go back to the questions that were put by Emma Harper regarding Near Me and other innovations? So Derek Lindsay wanted to respond to those, particularly around assessing the value of those interventions and their ongoing importance. Derek Lindsay.
Thank you. It was really just to build on what Hazel said, and technology-enabled care is something that we have had in place for some time, but has again proved its worth and is something that we would wish to take forward. So this is about supporting patients in their own home and using technology to do that. So patients with COPD and other health issues can be supported using technology-enabled care. And just from an administrative point of view, the use of Microsoft Teams has been something that has saved staff time and staff travel costs, whether that's attending national meetings or working across sites. That has been a benefit to us.
Thank you very much. And I call my colleague David Torrance.
Thank you, Convener, and good morning to witnesses. My questions are around the impact of COVID-19 on the 2020-21 budget. On balance, over the whole financial year, would you expect additional costs from COVID-19 to be offset by reductions in expenditure elsewhere?
Derek Lindsay.
So the straightforward answer to that is no. The longer answer to it is the additional costs incorporate a range, and I mentioned a number of those in my last answer in relation to social care costs, for example, sustainability payments to care homes, the cost of personal protective equipment, the additional costs of testing, and us having to recruit extra staff to do testing, also to analyse that within the labs and to do contact tracing. So whilst we do have an offsetting cost for savings that, or for costs that we haven't had to incur, so examples of that would be for supplies costs, which, because we haven't been doing hip and knee operations, the cost of those implants is a saving. Some of our staff who have been redeployed to cover other areas are an offsetting cost to the additional cost of the extra beds that we've had to open. However, as we move forward with remobilisation, those staff are now working back in their core areas, whether that's outpatient, surgical, theatres, etc. And therefore, we're having to recruit additional staff for the remainder of the year to carry out the additional functions that I mentioned, and therefore that's why there is a net cost increase.
Hazel Borland.
Thank you, Convener. You've mentioned some of
can I take Hazel Borland and then I'll come back to you in a moment. Hazel Borland.
Thank you, Convener. Just to build on what Derek has explained, then there are some additional issues that we're very cognizant of across the whole health and care system that may impact on the budget both in the short term and long term. So we're very thoughtful about the impact on children and families across our whole community and the impact and needing to meet their health and care needs from a physical and a mental health perspective. We're thoughtful about the rise that we're seeing in other countries who've been through the pandemic scenario and learning from them in terms of the potential public protection activity increase that we will need to make sure that we can meet across our systems. And also we're thoughtful about the additional stretch of the infection prevention and control requirements that we're going to need to address very differently on a long-term basis. So those are three very specific examples where we're thinking across our whole health and care system about what the impact will be in terms of being able to meet our community's needs, and therefore what impact might that have on the budget going forward. So it was just to build on Derek's answer to that.
David Charles.
Thank you, Convener. You mentioned additional costs. Can you put a financial figure on them for over a year? And finally, would you expect the Scottish Government to provide money for all these additional costs?
I'll take Derek Lindsay and then come back to Hazel Borland for the wider question. Derek Lindsay.
So the answer is yes. Within our financial plan that was submitted to Scottish Government along with our remobilisation plan, the cost for this year, the additional costs, net of the areas we've been able to reduce those, are £67 million. So we do expect Scottish Government to provide that funding from the consequentials that they have received from the UK Government for this.
Thank you very much. Hazel Borland.
Thank you. Just to echo what Derek has said, in terms of we've made a measured judgment on what we need to be able to continue to deliver our services and recover and restart our services in the light of the context of COVID, and how we will do that with the additional workforce needs, with the additional taking account of the potential health impact that we're going to need to look at as well across our whole system and our communities. Then I think at this point in time, then there is an anticipation that Scottish Government will meet the needs that we've outlined in our financial plan that sits alongside the remobilisation plan.
Thank you very much. I now call Sandra White.
Thank you very much, Convener. I don't know if you can hear me or not. I think you can. Thank you. All of the questions that I was going to ask in regard to finance and budgetary outcomes have all been answered, and thank you very much for that. Very pleased to see that the innovative changes you've made are actually going to come on board and for the future as well. So you're working very closely with IGBs and the local community as well. So my question to you is, now that you are working very closely or even closer and lots of barriers are broken down with the IGBs, would you be increasing their involvement in the decision making in regards to budget saving along with the board?
Hazel Borland.
Derek may want to come in on this as well, but the way we work in Ayrshire and Arran, we are already very well connected and very collegiate in our decision making across our health and care system. So, for example, our 3 partnership directors are part of our health board senior management team. We make those decisions as a collective. We are very clear about the decision making rolling through our IJBs and our NHS board in the sequence that it needs to, from a budgetary perspective, and their decision making to make sure that the governance elements of those things are met, to make sure that we are inclusive of everybody that needs to be cited on and participate in those decisions. We're trying to be much stronger in terms of any of those budgetary decisions that need to have directions between the IJBs and the health boards and indeed the council, so that we're working very closely as that triumvirate of IJB, NHS board and local authority in the way that the integration of the health and care system from a governance perspective was designed to work. And so we're already working very closely in terms of that decision making. From a budgetary perspective, Derek may have a view in terms of what that needs to look like from a governance perspective and any limitations there may be around that from a legislation perspective.
Eric Lindsay.
So I would agree with what Hazel has said, and we do align our budget setting process, and indeed the Section 95 officers from each of the 3 IJBs within Ayrshire and Arran are part of our groups who look at cost pressures for the future year. One area which I guess is slightly different in terms of NHS compared to the IJBs or the Health and Social Care Partnerships at the moment is, for NHS, the provision of personal protective equipment is purchased on across the whole of NHS Scotland by National Services Scotland through National Distribution Centre, and therefore is received free of charge. For our health and social care partnerships, the default position is that they are expected to buy for their own staff, as are care homes, the personal protective equipment, but there is a safety net and there is available personal protective equipment which can be provided if those supply chains don't work. So there is a national option appraisal going on at the moment around the best way to deliver that, because our council and health and social care partner colleagues are finding the costs have gone up significantly for personal protective equipment, and there may well be benefits in that purchasing to be done on on behalf of all of us for the one place. So, for example, our health and social care partnerships are estimating that they will spend about £5 million on personal protective equipment this year. So if there was an opportunity to reduce that through national procurement, that's being looked at the moment.
If I could just come back on that. Thank you. I forgot to say good morning to our witnesses. Good morning. Thank you very much. That's a very interesting point, because what has been raised with me in regards to, and it was mentioned earlier on, about schools going back and people being tested, it has been mentioned to me that should schools provide protective masks for pupils and teachers, and I just wonder if you had thoughts on that in regards to what you've just said, because I think that's a really interesting point for us to bring forward and clarify from this committee. One of the reasons I ask about the schools is that I'm very conscious that some kids will wear designer masks and some won't, and it would be really good for schools to be able to actually give out these masks so that all of the kids are not disadvantaged if they can't afford a designer mask. So do you think that would be something, or has it been raised with yourselves through your meetings with COSL and the local councils?
Hazel
So at this point in time, I'm not aware of discussions on that issue, but it's a really interesting one. So if I put that in the context of the NHS alone, then we expect patients and families who are coming into our settings to come with a face covering or a mask of their own, but if they don't have one, then we have them available for them to wear as they enter the building, so they are available. I'm not sure what the discussions have been with education colleagues about how that would translate into the educational setting, but I think it's probably a helpful conversation that could be had across schools for the very reasons that you describe.
Thank you very much for that, and I think I obviously would ask the committee to look at that, idea, or look at the comments that you've come back with, and Derek as well, because I wasn't aware that there were separate ways to, separate budgets and separate ways to get face masks. So I think that's a very good thing that this committee could follow up on. That's the last of my questions, Convener, and thank you very much. Thank you.
Thank you very much. And can I ask a final question around the impact of funding and the balance between hospital and community care? Can I ask how far the changes resulting from the pandemic have resulted in any shift in the balance of care between hospital and community, and what the impact of that will be on funding of IJBs, and in particular on set-aside budgets going forward? Hazel Borland, first of all.
So we have realised that during the last 5 months, it's not been as straight down the line as a shift in the balance of care. What we have done is made sure that the right care is being provided in the right place at the right time by the right person, and so across a variety of settings, sometimes it is right and proper for the person to come into hospital, sometimes it's right and proper for them to be in the community. I think one of our biggest learnings has been across our primary and community care setting, and how we've worked with our primary care colleagues and our GP colleagues in ways that we've been able to enable them to continue to provide services during this time. And I think some of that learning about how we provide primary and community care, and indeed urgent care, and how we could schedule that urgent care in a very different way in our community, that's been a very big element of our learning. So at this point in time, not so much about shifting the balance, but making sure that the person who needs that care is getting the right care in the right place at the right time, and making sure that we're really taking forward that in terms of our 10-year vision, and that Caring for Ayrshire, which is absolutely about making sure that a significant amount of care is provided in the community, and making sure that we've got those connections right.
Thank you. And finally, Derek Lindsay.
Thank you. So East Ayrshire Health and Social Care Partnership are the lead partnership for our Ayrshire Unscheduled Care Service. So that includes out-of-hours doctors, but what they have also been delivering for us is the community hubs over the period of the pandemic, and the future of those going forward is seen as being significant in terms of managing the emergency demand on our emergency departments. So that is a potential shift in the way, and as Hazel mentioned, instead of people turning up at the emergency department to try and triage in advance of that and then schedule the people who do turn up at emergency department. So I think that is one tangible shift that we are doing a lot of work around to see how we take that forward.
And finally, is there an impact on set-aside budgets from any of Derek Lindsay?
So the set-aside budget is really the element of our acute budget which is associated with certain specialties. So it is, by definition, the set-aside is within acute services. So I think it would be marginal in terms of the impact of that, but what I described about emergency services, they are part of that set-aside budget. So were there to be a shift to requiring less in the emergency department and more in the community hub, that's a potential shift, but I think it would be at the margins.
Thank you very much. That's very helpful, and thank you to both our witnesses this morning who've answered a range of questions. I know, Hazel Borland, you also offered to provide us a little more detail as well, and I'm no doubt will write to you following this session. Thank you very much. That concludes the first item on the agenda. We will now suspend briefly in advance of the next item. Can I remind members we remain live? It's a 2-minute suspension only in order to allow other witnesses to join us. So I now suspend this meeting. Thank you very much. We will now resume the meeting. We will move, first of all, to agenda item 3, which is in relation a made affirmative instrument. We will then return, after we've considered this instrument, to agenda item 2, which is 2 negative instruments, also subordinate legislation. But let me start with agenda item 3, which is the Health Protection Coronavirus International Travel Scotland Amendment number 9 regulations of 2020. Colleagues will recall these regulations are laid under section 94(1) of international travel of the Public Health etc. Scotland Act 2008, which states that such regulations should be subject to the affirmative procedure, but also that the affirmative procedure will not apply if Scottish ministers consider they need to be made urgently, and in such situations section 1227 of the 2008 Act applies. That sets out that emergency regulations must be laid before the Scottish Parliament and will cease to have effect on the expiry of the period of 28 days, beginning with the date in which regulations were made, unless before the expiry of that period the regulations have been approved by the resolution of the Scottish Parliament. It is for the Health and Sport Committee to consider these instruments and report to Parliament accordingly, we are joined today by the Cabinet Secretary and his officials to consider this instrument. So I welcome to the committee Hamza Youssef, Cabinet Secretary for Justice, who is accompanied by Rachel Sunderland, Deputy Director of Population and Migration Division, Jamie McDougall, Deputy Director, Test and Protect Portfolio, and Anita Poppleston, Head of Police Complaints and Scrutiny, all of the Scottish Government. Welcome to the session. I wanted to ask to first of all indicate to the Cabinet Secretary we had a full session last week, and I know you will be preparing a response to the questions we put to you then, so I don't intend to rehearse those questions in any detail, but I wonder if you would indicate the impact of these regulations, and in particular tell us the reason for those being brought forward at this point in time. Cabinet Secretary.
Good morning, Convener, to you and to the committee. I hope everybody is in good health. Yes, of course, Convener, on the back of quite a lengthy session last week, I received your letter, and of course I intend to give you a very detailed response. And of course, if anything in that response you feel you need further clarification, of course I'm more than happy to provide that, be that in writing or indeed, of course, appearing in front of your committee, which I suspect will be a fairly regular occurrence due to the nature and speed at which cases of the virus unfortunately are progressing in a variety of countries. In relation to the regulations in front of us, again, you'll remember that we receive the data from essentially 2 sources to help us make our assessment on whether a country should be removed or added to the exempt list from quarantine. Essentially an analysis from the Joint Biosecurity Centre, the JBC, as it's known, and that will look at a range of data, but also a risk analysis by Public Health England as well. We've now got into a pattern where we'll receive that data generally on a Wednesday and have that conversation on a Thursday with the 4 nations and come to an agreement about what countries should or should not be removed. In this case, in the case of the regulations in front of us, what we saw in particular with France was a challenging situation where the cases rose in the space of a few days to quite a worrying level. But we were quite reliant, and this is some of the challenge we face, we're quite reliant on the French government producing that data, which they did quite late in the evening, and therefore we had to make a decision, and we had a 4 nations call from memory at around about 9:30 that night, and made an announcement at around about 10 o'clock or maybe just thereafter, because we were so reliant on that data. So to put it in short, particularly for France and the Netherlands, the rise in the number of cases per week was worrying. The increase in the test positivity was deeply alarming, and the general trajectory in which those countries were going on gave us enough rise for concern to remove them, as well as the other countries mentioned, the regulations, off the exempt list.
Thank you very much. I'm going to ask if other colleagues have questions, if they could indicate those to me just now. But in the meantime, thank you for that response. And presumably, Cabinet Secretary, what you will then do is continue to monitor numbers from France and the other countries you've described. I think we've seen, and we'll come to this later, I'm sure, in a later meeting, but I think we've seen in recent days a country being added to the exempt list and then removed again very quickly. Is this simply a function of the process we're engaged with, and what is your view in relation to the countries that we're dealing with today? Are these all countries that you will continue to monitor in the same way with a view to reintroducing exemption when it's safe to do so?
I think that's a really good question, Convener, and my honest answer is that, and I hope I've been very clear about this publicly, is that even if a country is added to the exempt list, so therefore you do not have to quarantine, that situation can rapidly change. We've seen that in a number of countries. Of course, we've seen clusters in our own country, of course, in the region that you represent, Convener, you know that well as well. So situations in a country can change really within a matter of days, let alone the space of a week. So the caveat to any country being added to the exempt list, or even removed, but certainly when a country is added to the exempt list, the very strong caveat I'd hope from all four nations is there is always a risk when you are travelling internationally in the midst of a global pandemic that the situation may change in a matter of days, particularly in a matter of a week. So yes, of course, we continue to watch and monitor the countries mentioned in this regulation, but equally we get, as I say, a risk analysis and data on a number of countries where we have some concerns.
Thank you. Clearly, what you described is I'm sure, correct, but the process has tended to be that when a country has been removed from the exempt list, there's usually a day, 2 days, 3 days notice given. For example, people travelling from the end of the week will be subject to this. Now, clearly that's convenient for people making return journeys in that time frame. Are you satisfied that from a public health perspective, that's the correct approach when countries are being removed from the exempt list? Cabinet Secretary.
Again, I think it's a really good question. So we've got to the process now whereby, generally speaking, this can change because we'll always act in the best interest of public health. But generally, we tend to have a four nations call on a Thursday midday, and we'll make a decision, an announcement on Thursday 5 o'clock, and usually the regulations will come into force on a Saturday 4 in the morning. That's a pattern the last couple of weeks we've tended to get into. But this is a really important caveat, and that is not always going to necessarily be the pattern, because if we have data that shows from a Scottish perspective that we have importations of cases from a certain country that are causing us alarm, then we obviously reserve the right to move at a quick pace because of the imperative and the public health imperative that we have. There's a really fine balance between ensuring that we bring in these regulations quickly as possible once we're alerted to a possible dangerous situation in the country, and at the same time making sure that there is at least a little bit of time for the border force, for example, to be able to operationalise that decision. And that's why there's a quite narrow window now between making an announcement generally on the Thursday 5 and then the regulation coming into force at Saturday 4 in the morning. But as I say, we'll tend to keep that gap between announcement and implementation as narrow as we possibly can, because of, again, we wouldn't be making these decisions if it wasn't because there was a public health risk.
Thank you very much. No other members have indicated they wish to ask any questions of the Cabinet Secretary or his officials at this stage, so we will now move on to agenda item 4, which is the formal debate on the made affirmative SSI, in which we have just taken evidence. I remind committee members and others that this is no longer a question session. It's not for officials to take part nor for members to put questions to the Minister, but simply a formal debate which members may or may not wish to contribute to. Can I invite the Cabinet Secretary to speak to and move the motion S5M 22436 in his own name? Cabinet Secretary.
Convener, again, I won't speak to the motion because we have obviously just exchange a few questions on it, but I'm pleased to move motion in my name.
Can I ask any members if they wish to contribute to this debate to indicate accordingly now? I see no such indications. Cabinet Secretary will want to formally sum up. And thank you very much. And then I then put the question. The question is that motion S5M22436 be agreed, be approved. Are we all agreed? We are. Thank you very much. That is agreed without division. Can I thank the Cabinet Secretary and his officials for their attendance this morning? And we will now move to agenda item 2, which we skipped over somewhat earlier this morning, but which remains before us for consideration. Item 2 on the agenda is subordinate legislation consideration of 2 negative instruments. The Scotland Act 1998 Agency Arrangements Specification Coronavirus Order 2020 and the Scotland Act 1998 Agency Arrangements Specification Coronavirus Number 2 Order 2020. Jean Freeman, the Cabinet Secretary for Health and Sport, wrote to the committee in July and provided a series of updates on the digital response to COVID-19. This included working with the UK Government on the potential for an app to be developed by the UK Government to be used throughout the United Kingdom. These instruments put in place the formal arrangements to allow this to happen by enabling an agreement to be reached between the Scottish Government and UK ministers on the operation of such a within Scotland by UK ministers. But it is not, of course, the agreement itself. It is simply the legislative framework to allow that to happen. Can I ask an indication for members who wish to comment on these instruments? I see Sandra White.
Thank you very much, Convener. I mean, I note the letter, and I note that basically the Cabinet Secretary has agreed in principle to this. But I would like to just ask for some clarification. I'm not moving against this SSI, but it mentions the app is intended to further extend the speed and reach of contact tracing in England, and should Scottish ministers so choose within Scotland as part of NHS Test and Protect. Now, there have been newspaper reports stating that people in England who have entered into the app that is being used at the moment have been asked for their bank details, and I'm concerned in regarding that. So I would like some clarification, perhaps by a letter in respect to that. And also in July, I believe, a question was asked of the First Minister in regards to Scotland, its own track and trace app, which would be similar to Republic of Ireland or the same as Republic of Ireland. So I just wondered where that was too. So that's just 2 points of clarification in regards to this SSI.
Thank you very much. I also see Emma Harper.
Thanks, Convener. I, like Sandra, I'm not going to. I'm going to approve this SSI, but I'm interested in the language around impact assessments. It says a full impact assessment has not been produced for this instrument as no significant impact on private, voluntary or public sector is foreseen. So I would be interested in some clarification around that language regarding impact assessments.
Thank you very much. I don't think I see other members seeking to come in on this. The points that have been made are by Sandra White and Emma Harper are in terms of seeking further information, but I think both indicated they were happy to make no recommendations in relation to this instrument. Clearly we can write a letter and seek that clarification from Jean Freeman in any case. We could, of course, delay approval of the instrument pending our response, but I think the indication from members was that they didn't want to do that, but simply to seek that information. Is that correct? I see Emma agrees that that is correct. Therefore, given agreement to write a letter covering these points and the other comments from the members, is the committee agreed to make no recommendations? That is agreed. Thank you very much, and we will inform Parliament accordingly. Thank you. We will now move into private session and resume in a few moments, in 5 minutes, on a different platform. So thank you very much, and we will resume at 11:35 on a different platform.